Good evening, good morning, good day, everybody. This is Susan Thornton, the CEO of the Cutaneous Lymphoma Foundation, and welcome to our first Facebook Live interview of 2018. And we hope everybody had a wonderful holiday season and Happy New Year to everyone. And tonight we have with us Dr. Larisa Geskin, who is the director of the University in New York City. Welcome, Dr. Geskin. It's great to have you with us tonight.
Thank you so much, Susan. It's my pleasure to be here with you and with all of you today, whatever your place coming from. It's my pleasure, and it's great to have everyone connected through the Facebook.
Yeah, it's amazing technology, and let's hope that everything stays working. Sometimes we do run into some technological challenges, so please bear with us if we run into any difficulties. But tonight, our topics, I think, quite timely to talk a little bit about vaccinations and flu shots and the shingles vaccination. We get a lot of questions about that, and I know you do as well. So we'll start with that, and then in the second part of our discussion, we're going to talk about phototherapy in a little more detail and end our discussion with a new clinical trial that's currently taking place in the arena of phototherapy. So let's go ahead and get started. I know the question always comes up, and I probably had 5 or 6 emails or phone calls from patients over the last several weeks once everyone starts talking about you need to get your flu shot. All of a sudden, everybody's asking, should I get the flu shot? I'm immune compromised. What do I do? Is that a good thing? Maybe we'll just start with that question, and then we'll go from there.
Questions that I'm being asked while I'm seeing patients, and it's exactly the way patients worry about it, because they know when you have a cutaneous T-cell lymphoma, your T-cells may not be working as well, and so they render state of at least somewhat being immunocompromised. And so we really want to subject anyone to anything harmful to them. But in this case, actually, flu vaccine is very safe unless you're allergic to some parts of the vaccine. So you're allergic to eggs. Some people may be allergic to eggs, which are part of the vaccine. It's really not a dangerous vaccine. So you have to distinguish, though, because there are 2 types of vaccines. One type is a live vaccine, and that's the vaccine that is given through the spray given into your nose. And that vaccine you should not get. That vaccine contains attenuated or weakened live virus. The second type of the vaccine is the vaccine that is given as a shot. It's a dead vaccine. It cannot cause flu, but patients sometimes may have a little bit of aches and pains as an immune reaction, which is a good thing. It's what we are trying to accomplish. We are trying to boost your immunity, in this case, to a flu. And it's a good thing that you're mounting that type of a response. It's not dangerous. It should pass within a day or 2, and you should be okay. The second question that I am frequently being asked is about other members of household and whether they need to be vaccinated or not. And of course, minimizing your exposure to flu is a good idea. So I think everyone around you should be also vaccinated. Now, whether they receive live or dead vaccine, it depends on your particular situation, and you should talk to your own physician specifically about this question. But in general, the rule of thumb is if someone is really immunocompromised, someone is after stem cell transplantation, or someone is receiving chemotherapy, the household should not get live vaccine. They should get killed vaccine as a shot. And so I think minimizing exposure, keeping distance from people who are sick, covering your mouth and nose, wearing mask, washing your hands, hand washing hygiene is extremely important. Covering when you sneeze or when someone around you sneezes, covering your nose, covering your mouth is very, very important. Protecting yourself is very important.
Good answer. Hopefully that was very helpful to folks, because I know it does get confusing and it's hard sometimes to differentiate between what you hear or what is advertised or what your friends tell you or your family tells you and what is clinically appropriate. So that's the right answer there. So let's see. How about the shingles vaccine? Now, that's a little different twist, right? As best as I know, in the past, the shingles vaccine was only offered as a live vaccine, right? But we've heard that there's a new option that's available. Can you share a little bit about what you know about that and maybe talk about the distinguishing on the shingles vaccine, especially since a lot of our folks in the community, myself included, are over 50, and that tends to be recommended, I believe, for people over 50.
First of all, I would like to thank Susan for bringing up to my attention that actually this new vaccine called Shingrix was just recently approved in October of 2017. So thank you for that. I did not realize that. So now we have actually a wonderful option on the market that should be covered by insurance and is something that will be accessible to everyone. It is currently recommended for patients who are 50 and older, but it hasn't been really well tested yet in people who are immunocompromised. But knowing from what I know about this vaccine, it should be a safe vaccine to use at any stage of any cancer. It should be pretty safe vaccine because it is a vaccine that is made of a killed virus. And actually, it's not even a killed virus. It's just a part of a virus that is highly what we call antigenic. It actually is a very strong stimulant over your own immunity against shingles. And it's highly, highly effective. It has what we call adjuvant, something that helps to mount that immune response, very strong immune response, and something that people can use even if they are immunocompromised and even if they're sick. They should not get sick from the vaccine, even though they may also get a little bit of aches and pains following the vaccine. But the vaccine itself does not cause shingles because it doesn't really have a live virus. The shingle vaccine, I just want to give maybe a couple words about the background and what it is and why we even talk about this. Why is it so important? Shingles are caused by chickenpox virus, and many of us as children or young adults had chickenpox. And when the chickenpox is gone, it actually is not gone completely from our organisms, from our systems. It actually stays in our nerves and what we call the little round endings of those nerves called ganglia. And the virus remains dormant. It just sleeps there for a long time. And it gets reactivated when the immune system is weakened. And what can happen when the virus is reactivated, it actually causes rashes that can affect any part of your body. It can affect eyes, it can affect ears, it can affect mouth and so on. And it actually can cause even blindness and some other devastating consequences. The most common and most devastating consequence that people experience is called post-herpetic neuralgia. It's the pain that follows the nerves, where the virus lives, and this is a quite devastating. It can be quite devastating consequence of shingles that impairs many people's lives. And so I really welcome this new vaccine that is safe. And we will wait for effectiveness data to come in, but in almost 40,000 people in whom it was tested, it was found to be 97% effective in people who are up to a certain age, and after age of 70 is still quite effective. So it's much more effective than the previous vaccines, because with the previous vaccine, our immunity was kind of dwindling with time. And so after 3 years, after 4 years, after 5 years, the immunity was not nearly as strong. And so with this vaccine, we do not have long-term data, but it appears that it's quite strong. And so we are looking forward to new data coming out from the research that are currently being made.
Wow, that's great and very exciting things. And another good use of research dollars and providing really great new treatments or new, well, in this case, vaccines. So good news for all of us, I think.
Yes.
Yeah,
it's currently recommended for everyone over age of 50. So I think it's good news for all of us, really.
Yeah. I had shingles when I was much younger, and I don't really ever want to have it again. Thank you very much. Mike, I'll just touch base with you. Do we have any questions about vaccines, either the flu vaccine or the shingles, that anyone wants to ask at this point in time before we kind of move into talking about phototherapy?
Yes, we actually do have some.
Okay. Okay, great. Great. Might be easier to answer them now while we're on the topic. Okay, so the question is, my mycosis fungoides broke out after my shingles vaccine in 2012. So you can retake this new one. I guess that's the question. Can you retake the new one?
So the mycosis fungoides broke out after shingles? That's what happened? Yes, did I catch it?
Yes, I guess it sounds like they were diagnosed with mycosis fungoides maybe after they got the shingles vaccine.
So this is a really interesting point, and I know we don't have much time, but I really want to make that point if you allow me. One of the things you have to understand about CTCL, mycosis fungoides, as a disease, it's a condition of T cells, and those T cells are semi-mature T cells. They are not normal. They're not quite normal. So when infection happens, infection like shingles, for example, happens, those abnormal cells may go to that exact spot and they can actually stay there and grow there. And it's not infrequently that we diagnose mycosis fungoides in places that people have skin rubbing against the skin, or infection of the skin appears, or something like that. And so we definitely know that those cells can proliferate in areas that are not surveyed in a normal way, the same way as we would have a area that is not sick, that does not have any infection or any damage. And so one of the things that is extremely important for the skin of my patients that I recommend is a diligent skincare and moisturization of the skin, protection from all kinds of infection. And shingles is just one of the types. And of course, it's a good idea to revaccinate so you can boost your immunity and you can stay immune against that very, very significant illness.
Okay, so this person says, I'm afraid of shingles. I've been thinking about getting the vaccine. This information is so appreciated. So we're glad that it's very helpful and timely. Okay, and if you had shingles within the last few years, do you still need the shingles vaccine? Good question.
So this is a very good question. Some people actually have shingles only once in their lifetime, and they mount an immune response that is strong and may last a lifetime. But we don't know that, and the test, I don't know if you want to have a test, if you want to sit and wait if you will develop another outbreak. So instead of sitting and waiting, this vaccine seemed to be very effective, and it's not live vaccine, as I mentioned. It actually has a particular part of a virus particle that mounts a very strong immunity against that illness, against shingles. So there is no harm in getting it and protecting yourself and just making double sure that you are protected.
Right. Good point. Matter of fact, I'm going to have to look into getting that new vaccine myself.
Me too.
Yeah, good point. Any other questions, Mike, from our?
Yes, we do have a couple more.
Okay, great. Happy to. Okay, all right, perfect. All right, so we're going to switch gears a little bit now and talk in more detail about phototherapy. You know, it's one of the mainstays of treatment, especially for early stage disease. It's effective for so many people. Maybe we can just start by understanding a little bit about phototherapy. There's different types. You know, people might have heard UVB or narrowband or PUVA is, you know, our acronyms and our words are kind of tossed around. But if you're a patient, you may not, and that you're kind of new to the game of cutaneous lymphoma, it doesn't make any sense, right? So maybe we should start there with a description of phototherapy, the different kinds, and maybe why we use it in this disease.
It's a huge topic that I will try to cover in 2 minutes or less. This is something that people study for many, many years, and I will try to summarize. So first of all, we all know that ultraviolet light is coming to us from the sun. And the sun carries all kind of fractions of UV light, UVA, UVB, UVC, and so on. UVA and UVB does reach the earth, and they can be used in with medical purposes. And we do use both UVA and UVB to treat all kinds of skin diseases, not just cutaneous T-cell lymphoma. The ultraviolet A light, UVA, is usually used together with a photosensitizer called psoriasis. And this is a very old compound that even ancient Egyptians knew about, that grew on the banks of River Nile, and they used it to enhance the light therapy on their skin. So it's been known for many years, but medicinal use only been around since probably around 1970s or so. And when we combine psoriasis, which actually spelled with the P, is just silent, it's called PS, psoriasis. We call that type of therapy PUVA, psoriasis plus UVA. It's a very powerful treatment, especially for people who have thicker lesions, for palms, for soles. The narrowband or broadband UVB, again, there are just different types of UVB, ultraviolet B light. And broadband, of course, is something that covers much broader spectrum. It actually goes from 280 to 320 nanometers in the width. And the narrowband is just a fraction of it, from 305 to 320. So it's a much narrower band of UVB that actually is quite powerful, and it's been shown that narrowband is maybe more effective than broadband. And so many people now using narrowband UVB for their therapy. The type of therapy that is best for you is best chosen by your doctor. It's just different types of UV therapy that we know. We know that UV light is killing the cells in the skin, and it's killing malignant lymphocytes on the skin, resulting in clearance of the skin. And in some cases, it can actually result in very, very long remissions that patients enjoy after using narrowband or most commonly PUVA therapy.
Oh, that's a lot to think about. So if I'm diagnosed and light therapy is recommended, let's just take UVB narrowband, for example. How long does it take to work? How long would someone need to do the treatments in order to start to see a result?
So this is an excellent point, because one of the things that you have to discuss with your physician is your expectations and condition that you start therapy with. Patients who have thinner patches, thinner plaques, they may respond faster, but faster is not overnight. And one of the things that I always tell my patients, I make an outline, I make a timeline, and I say, well, in 2 months, we can expect something like that. It's not always the same, but I would give at least good 2 months of light therapy before making a decision whether it's working or not. Many patients with CTCL, mycosis fungoides, respond extremely well to light therapy. Patients who even have what we call more advanced disease, even for those, phototherapy may be quite beneficial, but it does take time to work. So it may take a couple of months before we know if we are really turning the corner or we need to switch the therapy.
So patience is important. And, and I know for many folks that if it's found through the treatments that the therapy is working, then at some juncture, right, they might be able to taper off and see what happens. How does that work for some folks?
Yes, this is another very important question, and unfortunately, I don't know if I have a great answer for you because we really don't have a great clinical trials looking at what we call maintenance therapy. And so there are different schools of thought about maintenance and about tapering down therapy. I can tell you what I do. Some people do something else, but I think in general, we think that the light therapy, when people completely clear, should be maintained for a little while. I usually do another couple of months of therapy after complete clearance, just to make sure there is not a spot left behind. And after that, we start what you call tapering. So if you use the light therapy 3 times a week, we start using it twice a week. Or if you did twice a week, we start using it once a week. And we slowly, over month, taper it down to nothing, to basically being light therapy free. But for some patients, it's not even possible because as long as they get light, they're doing great. But when you start tapering, they relapse and they may experience new symptoms. And so their skin tells us how frequently the maintenance therapy should be. And so I always look at my patients during tapering time very closely because their skin is telling me how far apart the treatments can be and how they can tolerate this type of therapy and if they can come off therapy completely, or if they become symptomatic, they become itchy, they develop new spots. And so I tell them, look, your skin tells me we missed the date.
We have some questions, Susan.
Now we have to go back, and now we have to initiate therapy again.
Okay, so it's an individual it's an individual therapy that you have to work collaboratively, right, with your physician and figure out what works best for you. There's no black and white answer.
Absolutely, and I have to actually add to that all CTCL therapy is individual, and in all CTCL therapy, you have to work with your physician, and it has to be a two-way street, and it has to be a discussion. There is really no golden bullet, no one therapy that is better than the other, and for that reason, I think it's really, really important to be to have that conversation, to discuss these things, and to find what's best for you.
Right, makes sense. Okay, Mike, we've got some questions, I understand.
Yes, we do. Let me grab one for you here and send this live. Here you go.
If used for long periods of time as a method of controlling cutaneous T-cell lymphoma? Great question.
It's a truly great question. It's really, really good question. And depending on the light source, the risk of skin cancer and melanoma, which is a dangerous skin cancer, may be increased by, especially PUVA, from 60 to 75%. So for people who are high risk, for people who already had melanoma, for people who had skin cancers, light therapy may not be the best choice. It may still be the best choice for you, but in general, it is not something that we go first to when we know that patient already had skin cancers or melanoma. The family history is very important. The previous sun exposure is very important. And the special skin type is very important. So we have to always take it all into consideration before we prescribe any therapy. But like everything else, light therapy has side effects, and this is one of the major side effects of light therapy is increasing risk of skin cancer and melanoma.
Right, right. Especially because it's a long-term therapy a lot of times, decades. I know folks have been doing light therapy for decades successfully, right? But you have to pay attention.
You have to absolutely pay attention, and you have to have this conversation with your physician in addition to looking at your skin and treating you for CTCL, mycosis fungoides. They definitely have to do what we call full body skin checks for skin cancer surveillance. It's extremely, extremely important.
We have more questions.
Okay, great. Next question. Hey, my mycosis fungoides is not currently active. Would additional light therapy sessions help keep it at bay, or is it only useful when it is active?
So, first of all, I cannot tell because I don't know you. And to answer this question, I really have to know a lot. It does seem like it's a simple question, but it is not. There's so much more I need to know to respond to any question and to be fair to you. So I think this type of question is best addressed by your physician. And unfortunately, I don't think we can predict who is going to relapse and when. And as I mentioned before, in terms of maintenance therapy, there are two schools of thought. One school of thought is that every patient needs to be on maintenance therapy at least once a month, or maybe at some kind of frequency. And there is some school of thought who thinks that people need a break. And it's okay to be off therapy for some time until disease comes back, because usually if disease comes back and new patches appear, they're really not difficult to treat if you're staying on top of it and you don't let it go. And so you can always initiate therapy if you see a spot coming out here and there, and you don't need to be on maintenance. So there are different schools of thoughts, that's all.
Right, right. So best advice is to have a conversation with your physician and work out your own treatment plan based on your history with your disease and how things have worked.
Yes, definitely.
Right, right. Okay, next question, Mike. Okay, is phototherapy more effective than VALCHLOR?
This is again another great question, and I don't think I can provide you a best answer because they never were compared head to head. And so the clinical trials were done on slightly different patient populations, and if you look at the numbers, they are quite comparable, right? So you see patients at certain stages having 80-90% response rates to both light and VALCHLOR. But I cannot tell you if it's true, or is it something that we just kind of look at and decide that maybe the responses are similar, because to respond to you correctly and not to hold anything back, I would have to conduct a clinical trial, and I would have to really compare it, head to head and tell you exactly what the numbers are. But I think the way to think about those two treatments is not necessarily what's more effective, what's less effective, but rather what's better for you. And again, we just discussed some risk of skin cancer and potentially melanoma, and how light may be contributing to melanoma. So maybe in some instances using VALCHLOR is safer than using light, and in some instances is the other way around. So again, it's a conversation to have with your physician.
Okay, next question. Oops, you got to switch the, no? Oh, there we go. I have lupus as well as mycosis fungoides, and I'm doing UVA once a week. Should I be doing it more than once a week?
This is a tough one because having lupus and mycosis fungoides, you know, light therapy in general is contraindicated in lupus. And I really cannot tell you what you should do because, again, I don't know the status of your lupus or the status of your mycosis fungoides for that matter. And so this is something that definitely needs to be addressed by a specialist, and all these difficult parts of the equation need to be taken together, and the answer can be created. But unfortunately, I cannot provide the medical advice like that, not knowing so much more about you.
Okay. All right. Next, is shingles contagious?
Very good question. I'm glad you asked. I forgot to mention this. This is extremely important. Shingles are contagious. They are contagious to the point when they are crusted. When they are crusted, they are not contagious anymore. But when they are little blisters and when they are little red bumps on the skin, they're very contagious. And so if you are around people who were not vaccinated against chickenpox or never had chickenpox, you can give them chickenpox, and they can get quite sick. And especially it's important if you are around women who are pregnant and who have not been vaccinated, because it's varicella zoster virus, VZV virus, is extremely harmful to the baby. And so being around pregnant women is extremely, extremely dangerous if they're not vaccinated. Traveling is very important. My patients travel a lot. They get on the airplanes. If you have shingles, you are contagious. You are putting at risk everyone who is on a plane if they're not vaccinated or if they're immunocompromised. So this is something that really needs to be addressed with your physician.
Oh, good question. Next question. No. Maybe. There we go. Go ahead, Mike. You can ask.
Hey, my mic. There we go. Is it okay to take the flu vaccine?
Yes, it's okay to take a flu vaccine if you are on chemotherapy or undergoing some kind of therapy that makes you immune compromised. You should get killed vaccine, which is a flu shot. People around you should also be vaccinated, because people around you should be, you know, they should protect themselves so they don't give flu to you.
Right, right. Yep. My son is 22, and I realize at low risk for shingles, but should he get the shot? I'm assuming he might have
MF?
lymphoma, yeah, MF, or yeah.
Maybe. This is again uncharted territory. It would be unusual for such a young person to get a flu vaccine, but shingles vaccine. But again, I don't know much about a person and how sick they are, or if they're not that sick. You know, if they're having what we call the hypopigmented mycosis fungoides, their immunity is usually fine. They don't need to be extra protected. But, you know, looking at that new vaccine, it appears to be fairly safe and effective. So I think under the circumstances, maybe it's not a bad idea to have that, again, I don't know the details. I don't want to give medical advice here, but I'm just thinking that the vaccine is safe and effective. And so if a person is sick, they are at risk, and, you know, you can use advice of your own physician when you bring it up and see what they say. But probably there is more good than harm can come out of it.
Right. So maybe a rule of thumb that, you know, everyone should at least ask their own physician about the new shingles vaccine, and if it would be a good idea for them to pursue that.
definitely. Yeah.
And Susan, we have a couple more questions on other topics here. The first one's on the screen.
So M at more risk now, currently diagnosed with swollen lymph nodes and a mass in the chest, other cancer risk. I'm not sure I quite understand the question. Are they at more risk now as they've been currently diagnosed with swollen lymph nodes and a mass in the chest for other cancer risk? I'm not sure exactly what the question is, but
I guess they're asking if once diagnosed, what are they at risk for? If they're at risk for infectious complications or other cancers. Again, I need to know exact diagnosis. I need to know exact status to respond to this. But in general, patients with cancer are considered to be more immunocompromised than people without. And so yes, people who have cancer are considered to be more at risk for shingles, for infections. With the flu, it's not quite clear because flu is such a contagious disease, and everyone, if they're not vaccinated or if the vaccine is not working very well, they may get the flu. It's not necessarily the immunocompromised status that make you sick. But with the flu, when you do have immunocompromised status, if you are sick, the risk is of complications. So flu can last for a couple of weeks and can be little aches and pains in someone who is quite healthy. But in patients who are not well, it can last longer and it can have a number of significant and even severe complications, and people even can die of flu. So we do recommend flu vaccine.
Okay, I'm going to read a few questions, Susan, because we're not able to populate them on the screen. Here's one. Can narrowband UVB be effective if the lymphocytes are around the hair follicles as well as in the upper levels of the skin?
So yes, narrowband UVB can be effective even if the hair follicles are affected, but it's not for it's not true with everyone. It truly depends on a particular patient and particular presentation. In patients who have true what we call follicular tropic disease that tracks down the hair follicles, in my opinion, the light therapy that penetrates deeper, such as UVA, works better. But you have to consult your own doctor to see which therapy is best for you, because the depth and the wavelength correlate. So the longer wavelength, the better it is for the disease that is deeper inside of the skin.
Okay, great. One person commented that VALCHLOR caused her to have an allergy contact dermatitis. She was using it after 4 months of UVB. Have you noticed that, doctor, occasionally?
Yes, it's actually quite notorious for causing contact dermatitis, and I actually recommend my patients to use VALCHLOR to the point that they have contact dermatitis. Contact dermatitis is not necessarily a bad thing. Contact dermatitis is also a way to stimulate your own immunity against cancer. And in fact, some other treatments that we've used in the past, we don't use them anymore, but they were actually directed to switch that immune response from something when your skin was not red and irritated to something that was red and irritated. Because frequently what we see with VALCHLOR, when it causes redness and itchiness and scaliness, we put a little bit of steroid on to help with that, with those symptoms of contact dermatitis. And after contact dermatitis goes away, we can see that the skin actually clears and CTCL goes away. So I think in this particular case, contact dermatitis may be your friend. You just need to know how to play it, how to use it for you and not against you.
Okay. I don't recall if we answered this one earlier. What are the risks of skin cancer with UVB if it's used for long periods of time as a method of controlling cutaneous T-cell lymphoma?
Yes, UVB is like other sources of light. UV light specifically is associated with skin cancer. And in the past, UVB was considered to be safe and was not associated with the risk of skin cancer. But we know now it's quite damaging to the DNA of the skin cells, and it causes degradation of collagen under the skin and resulting in skin sagging. It causes also somewhat immunocompromised because it's obviously removing the white blood cells from the skin, and with the malignant, with the bad cells, it removes the good cells too. So it may also decrease your skin immunity.
Okay, and we had a couple of questions on total skin electron beam treatment. Somebody just finished TSEB. They want to know how long does the clearing usually last after going through that treatment, and what is the success rate with that treatment?
Well, electron beam therapy is one of the most successful therapies we've got, and for that reason we use it very judiciously, because there are only so many times you can have that treatment during your lifetime, because it will start disintegrating your skin if you get too much electron beam radiation. So what we usually recommend is to clear the patient with electron beam and then maintain that clearance with something else. We know it's almost 100% effective in CTCL. So all the patients who undergo electron beam therapy, they do well, they clear at some point, and they stay clear for some time. Unfortunately, we don't know for how long it's going to last for one individual patient, but as a group, we know that the remissions after electron beam may last for a few months, up to a year, maybe even longer for some patients.
Okay, and just a couple more. Somebody had asked about some of the, oops, sorry about that. Let me just, I'm monitoring here on Facebook, so let me just kill that audio. It's nice to hear yourself twice. Somebody asked, can any of the medicines that are approved and appear to be so effective for psoriasis lately, can any of those be modified to be effective with cutaneous T-cell lymphoma lesions to treat those?
Well, it's a great question, and I'm glad somebody asked this question, because actually some of these therapies for psoriasis have a black box warning about lymphoma. So actually some of the therapies for psoriasis cause lymphoma or associated with lymphoma. So some of those therapies are absolutely contraindicated if you suspect to have lymphoma, because they actually can fuel lymphoma and make it much, much worse. Majority of therapies for psoriasis are immunosuppressing, and this is really not a good idea to use those to get rid of white blood cells on the skin, because it actually causes the opposite effect. And some newer therapies that may be more safe, and they may not be necessarily as bad for you and may not be as contraindicated, but we just don't have enough data yet, and we don't have enough knowledge yet about those drugs and how they are, what kind of effect they have on immunity long term. They're fairly new drugs.
Okay, great. Well, I think we have, I think just one more question that I can find, and I do apologize. There have been so many questions. I hope we got through all of them. By the way, Jacob G says, hi, Mom. So I'm not sure which one of you that's directed at, but or somebody in the audience. But anyway, I do, let's see, the question is, let's see, I have lesions on the brain. Does cutaneous T-cell lymphoma cause that?
Well, I have to say it's quite unusual for cutaneous T-cell lymphoma to cause brain lesions, even though things do happen. But I think if there are brain lesions, they need to be investigated. Most likely, they may not be related necessarily to cutaneous lymphoma.
Okay. Well, thank you so much. And Susan, I'm going to pass it back to you. But we had some great questions from the audience, didn't we?
Yeah, it was great tonight. And I also want to be conscious of Dr. Geskin's time here, since it's almost 10 of 9. So I know we probably could talk for another several hours. Maybe we'll just wrap up really quickly with a quick, can you just share a little bit about the FLASH trial? Because I think it's pertinent to, it's a brand new type of light therapy versus it's not UVB, it's not UVA, it's something different.
Yes, and I'm glad you asked that, because it is so exciting that we now have this brand new therapy on horizon. We are testing, we are looking into how effective it is and how people do on it. But the idea is quite exciting because it uses light therapy, which we know is very effective. Light therapy, electron beam, all the skin-directed therapies are very effective in patients with early stage mycosis fungoides. But it uses fluorescent lights, the same lights when that go off when you turn on the switch in your room and you see the room lit up by the light. It's fluorescent light. But to make those fluorescent wavelengths, those fluorescent waves work well, we need to use a special medication, like a gel that we put on the skin that will make the skin susceptible to that UV light. And so what we do, our patients put a cream on the spots that they have, and then they come in and we irradiate them with a fluorescent bulb. They can go out on UV light. They will not get burned because this medication is not activated by UV. It's actually activated on fluorescent light. So when you're in a room, you have to cover up, but outside you do not. And so you can actually go outside and enjoy your light and life and enjoy outdoors and not worry about being burned, because it is very safe, and it's very, very different from Sorolin and other photosensitizers that we use for UVA therapy or other UV-based therapies.
It's very exciting, and it's currently in phase 3 clinical trial, right? And I believe there's still
and we're enrolling, and it's in the enrollment is going well. We just enrolled, we just opened, and we're enrolling patients every day. So it's something that is a randomized trial. So for the first 6 weeks, you don't know what you will be getting, placebo or the drug. But after 6 weeks, you will get an active drug. So patients are willing to bear with us and donate their time and effort and to be on a trial and to let us all learn from their experiences.
And how can patients find out if they qualify for that trial or where the trial sites are?
Well, they can go to our website, the Cutaneous Lymphoma Foundation. It's called the FLASH trial. And if they go under our clinical trial page, they can search for the trials in their state and see if any of the centers are actually participating. You can always go out to clinicaltrials.gov. That's a little harder to find things. So I would just say check our website and then ask your doctor if they are actually participating in the clinical trial.
Yes, I would highly recommend going to Cutaneous Lymphoma Foundation website. It's a well-organized and well-run website with all the information that patients ever need to find out about clinical trials in your area. And we're all there for you to help you to navigate through this.
Right. Absolutely. Absolutely. Well, I think that's a really great note to close on. Mike, I'll just do one last check for questions before we let Dr. Geskin go and enjoy the rest of her evening.
Okay, yeah, I think we had, let me see here, a question about no topical treatments have been helping me. So I only use Aquaphor on the skin and take Methotrexate now. Is that enough? It's still spreading, but it does go away, and then it goes to other areas.
Well, that's a tough one. I don't know if it's going to be our last question. I would hate to end on a question like that, but it's a tough question. I think it's quite impossible to answer this question without knowing so much more about type of your disease and what kind of cells are there under the microscope and what else is going on with you. it would really be a huge disservice to you to provide a medical advice based on information that was provided for all of us right now. I think we are better off talking to a physician and addressing all these issues and seeking second opinion or third opinion or whatever opinion you may need to have. But it's really impossible for me to tell you what the best therapy for you at this juncture.
Okay, we do have another question, so we don't need to end on that difficult one. Here's one. My son, who's 46 years old, tans when his skin is broken out badly, and he uses olive oil on his skin and takes 0 medications. He refuses to go back to the doctor that diagnosed him. I think he's in denial. Any suggestions there, doctor?
Children. It's tough. You know, I think every patient needs to be monitored by a physician, and you don't have to accept all the advice. You don't have to accept recommendations, but just for someone to keep an eye on you, to make sure that when something is happening, someone is watching over you and advising you at that time. You can change your mind. You can choose and pick and decide at any point, but I don't think it's a good idea to have just self-therapy. Nothing good ever comes out of it. I think people are way better off when they're monitored. So I would advise to find a physician that you're comfortable with and to whom you can share all these concerns, because they are legitimate concerns. We acknowledge them. I see patients all the time who tell me, you know, doctor, it's not that I don't like you, but I hate being here. And I understand this. Who wouldn't? And you know, we have wonderful support groups. We have Cutaneous Lymphoma Foundation, who runs lots of educational sessions, which are, in my humble opinion, is the most beneficial thing for all patients. It's really something that I highly, highly recommend, to find a support group around you, or if you even need to travel, it may be worth your time. So this is something that I think needs to be addressed on a deeper level, and definitely I'm happy to help with the Cutaneous Lymphoma Foundation here together.
Okay, and one last question. How does large cell transformation affect cutaneous T-cell lymphoma?
Oh, hard questions.
I should have, answered the first one, right? You have to be mindful what you ask for. It is a tough one again. The large cell transformation is a type of transformation that we see when disease progresses. Now, having said that, not all the abnormal cells under the microscope can be called large cell transformation. Sometimes people overcall it when they see few cells, or sometimes there is a condition that is completely benign. It's called lymphomatoid papulosis that may look like large cell transformation in a setting of mycosis fungoides, but the patients do not have a true large cell transformation. So large cell transformation is really a very specific subject, and something that we are very careful about when we evaluate our patients. And this is something that has to be, again, addressed by your physician to make sure that you have a large cell transformation and not concurrent lymphomatoid papulosis or some other skin conditions that may have similar histological findings, but you in fact don't have it. So I think knowing a lot about the disease is a must when you deal with someone who has a large cell transformation. So, but in general, it means disease progression and changing of disease behavior.
All right. I think we got to all the questions, Susan. Just two things. Michael Young from the board of the Cutaneous Lymphoma Foundation checked in to remind us that we're going to be sharing the video. The video will stay up on Facebook and all these groups and pages where you currently see it. particularly on the Cutaneous Lymphoma Foundation's Facebook page. It will also be going up on the Cutaneous Lymphoma Foundation's YouTube page. So be sure to like the YouTube page. And Susan, we want to mention that next month on February 12th, Dr. John O'Malley will be joining us, right?
Yes, yes, absolutely. And he's going to be talking about his research project on trying to understand the progression of disease and why some people's disease progresses and some people's doesn't, and how we're trying to look at researching that whole topic. So, which is really important, and we're learning a lot, and Dr. O'Malley is doing some really interesting research along those lines. So, and in March, we'll be talking with Dr. Lauren Pinter-Brown. So stay tuned. And let's see, if you go to our website, you can look up all the events that are coming up. But like Dr. Geskin said, please come to one of our patient education programs. We're kicking off our spring season in Seattle with an evening program on March 23rd. Don't quote me on that. I think that's the right date. And then in April, we will be in Detroit and in Denver. And in June, we will be hosting our annual 2-day patient program in Washington, D.C. this year. So, and we're currently scheduling our programs for the fall. So we're trying to get around the country. Hopefully we'll get somewhere close to you. But if not, we'll be continuing our Facebook Live interviews throughout the rest of the year, and trying our best to bring all these wonderful and amazing experts right into your living room so that you can ask these kinds of questions. And I'd like to really take the opportunity to thank Dr. Geskin for giving us an hour of her evening tonight and answering all these questions. There were some pretty tough ones tonight. Really appreciate your time. And I guess from my perspective, one of the takeaways is it's really important to be seen by a specialist in cutaneous lymphoma and to be monitored by someone who knows the disease. And it's also important to have a good relationship with that person so that you can have a dialogue and a discussion and figure out what's best for you at whatever point in your disease you are in. That makes sense. So anyway. Absolutely. Any final comments, Dr. Geskin, before we let you go?
I think I could have not said it better myself. I think relationships between physician and a patient are extremely, extremely important. And I think trusting your physician enough and being comfortable is very, very important. And we are very fortunate because we are having many specialists now, the old specialists like myself and young specialists like Dr. O'Malley, who is coming in, who is wonderful. I just want to vouch for him because I know him well. He was our resident at Columbia and chief resident, and actually he took care of some of my lymphoma patients and did a good job. And he is a wonderful physician and a wonderful scientist. So I hope he'll tell you lots of interesting things next time. But it's very, very important to find someone you feel very comfortable with, and you can ask them anything you are worried about.
Fabulous. Well, we're going to let you go, but thank you again so much for your time tonight. And we wish everyone a really lovely evening and week, and all the best for a great 2018. And if you need us, call us, send us an email. We're always here to try to help. So with that, we're going to sign off. Thanks, everybody, and we'll see you next month. Take care and have a good night.